this is very timely, and I'm going to show you some background data for the nation and the state to lead us into where we are here in Northern California. But let me just start with, because this is a very mixed audience of folks who may not really know much about CMQCC, give us a little background about what we are, what we do. We're a multidisciplinary, multi-organization coalition established in 2006 to help improve maternity care in California. We've done major programs for reducing maternal mortality. That's been in the news a lot recently. California now has 1/3 the US rate of maternal mortality, focused on hemorrhage and hypertension. Now we're working on reducing C-sections, so we don't shy away from big, tough problems. To work on big, tough problems, you have to work with everyone. This is multiple organizations, community organizations as well as medical organizations, and you have to be able to do it in a holistic way. And that's the approach we're going to be talking about, above and beyond treatment, but what it takes to really move the dial and improve maternity outcomes. We've been working on this nationally through the AIM project, which I'm also the national implementation director of, which is multiple states. As you will see, California in this case is behind the rest of the country, which is a good thing. But we've now been able to leverage what the learnings have been in Ohio, West Virginia, Massachusetts, New England, which are sadly way ahead of the game on this. And so we've been able to package in a quality improvement toolkit the learnings from other states that are more advanced by their happenstance. So CMQCC has really been the product of the partnerships between the Department of Public Health in California, our Medicaid agency, Medi-Cal, ACOG District 9, and the Hospital Association. All of those bring a lot of resources and important angles on this process. Let's talk about some of the data. This is US drug deaths over the last decade. Is estimated in 2017, 72,000 Americans will die from drug overdoses. So this is an interesting slide comparing where we are with overdose deaths from opioids compared to other major public health emergencies at their peak. So here the peak of deaths from firearms, homicides from firearms was in 1993. That's the light blue line. That was almost 20,000. HIV deaths at its peak was 1995. Car crashes in 1972 was over 60. What we see projected in 20C is off the scale of this, way advanced, way beyond even car crash, annual deaths from car crashes. The drugs are now changing as well. Whereas you look in the green line in the middle was natural and semi-synthetic opioids. That's now overcome by synthetic opioids other than methadone. This is very concerning. They're much more potent, much more difficult. So this also then moves to deaths from substance use in pregnancy, which is obviously my role as a high-risk obstetrician who takes care of medical complications in pregnancy, including opioid disorder. So what we see here is that substance use or overuse, and this is Illinois, one of the harder hit states, but this was back in 2014 data, published in 2016, that it was higher than the usual causes of mortality in pregnancy, which is hemorrhage and preeclampsia and so forth. Similar deal in Massachusetts, again, one of the hardest hit areas. They've seen a rise in pregnancy-associated mortality, which is defined as deaths during or within a year after birth. Okay, importantly. This is obviously scary to all of us who take care of mothers and babies. And indeed, most of the deaths in here don't occur during pregnancy or in the first 6 weeks afterwards, but in that period, 6 weeks to a year. And that's one of the take-home lessons we have to think about here as we provide holistic care for mothers. Is it's pretty intense what we do in prenatal care and immediately afterwards. You get weekly visits, monthly visits, and then you cut the cord. And the mother's left to fend for herself in many settings or with much less intense care, and this is kind of the result that you see. is that there's a lot of issues going forward that we have to deal with. And what's, again, if you're looking at healthy babies, you have to have a healthy mother to go with it. So as mentioned, I chair the maternal mortality review for the state of California. We had not seen such a big rise yet, and you'll see the data showing that we are behind, but perhaps catching up. 7% of all the pregnancy-associated deaths, which is not quite maternal mortality because these are a lot of causes that have nothing to do with pregnancy, including motor vehicle accidents and the like, but it's still 7% of the deaths. So this is a real phenomenon, even here in sunny California. So this is the big slide about how we compare across the nation. As you can see, the big red areas in the Northeast are where the opioid epidemic has been, quote, ground zero. New England, Ohio, Illinois, and those are all states we've had the privilege of learning from. So this is CDC data comparing opioid deaths in 2 time periods. The red area is California at the very bottom. And there's 2 dots here. One is 2010 and one is 2015, showing the change over time. And what you see at the very top in West Virginia, in New Hampshire, is they went from low to very high in that 5-year period. So it didn't take very long to have this really take off. California, as you see, didn't change that much in that 5 years yet, being nearly at the very bottom here. California is a big state. Geographically, many different parts of the state, many different local, shall we say, ecoclimates, and you can see variation within our state. The red areas here are the ones that have the highest rates of overdose deaths, okay? And they cluster in our rural areas, including Northern California, in the eastern slopes of the Sierras. First of all, we should point out that these also are the same places that have the highest rates of maternal opioid use and the highest rates of NAS. They all go together. I'm going to say that again and again. Overdose deaths go with prescription use high rates of prescription use of opioids, high rates of maternal use, and high rates of NAS. Next. So this was a study that CHCF funded that was in the Urban Institute, looking not only at NAS incident rates for a 10-year period, but buprenorphine prescriber locations and in particular ones that had specific for care for pregnant women by county. Next slide drills in a little bit more in Northern California, allows you to see it. And here you can see the NAS rates again, like the earlier slide, showing a lot of them in our far north counties, which you all are really aware of. And you can see there aren't many yellow dots there where folks have a lot of experience caring for pregnant women. Next slide shows you Partnership Health Plan, which is the same area we're talking about in that last slide. Very good, extensive overlap. And what I did in the right-hand slide was show the annual births per county in this catchment area. And it's quite variable. There's some tiny counties up there, 200 births a year. This is all births, not Medicaid births. All births represented here. And some that are 1,300, 2,000 in Marin, 4,000, almost 5,000 in Solano and Sonoma counties. So there's huge variation in population and birthing rates here, which is an extra challenge. You know, some of the best work actually in the country on this has come from Vermont and New Hampshire, which is also kind of like Northern California, very rural areas, a lot of hospitals that have 200 births a year, yet they've been able to do a really pretty good job on this. So this is all an introduction to the National Safety Bundles. The Council on Patient Safety in Women's Healthcare is a multi-organizational effort of the National American College of OBGYN, the Nursing Association, the Midwifery Association, AMCHIP, the public health organizations, and many others, and to develop quality and safety bundles. We've done those for hemorrhage, for hypertension, for maternal mental health screening, and now we've turned to opioids. These are typically published They're online, but they're also then published in our specialty journals simultaneously. So I was the lead author in the one for hemorrhage, and we published it in Obstetrics and Gynecology, the Midwifery Journal, the Anesthesia Journal in that case, as well as the Nursing Journal. They all have a similar structure in terms of readiness, recognition, response, and reporting. We'll go through what we've done for opioids here. Anytime you have a big bundle, there's always the challenge of what do you do first? What's the first steps, and how do you organize your implementation approach? And so what we've done at the national level is do an implementation guide to the bundle. And it's almost like you need a guide to the guide to the guide a little bit, but sometimes that's very practical. So this was published and released a year ago. The bundle itself on our website, we're going to go through where to get it and the complementary materials for it. We have a commentary in press, and the implementation guide is what is brand new, and that has also just been released. So let's start for a moment and say, what do you really want to have achieved at the end of the day by this kind of work? And so the goals of the bundle are, first of all, to identify women who need help to begin with. So the first goal is to improve the identification and then referral to care of women with opioid use disorder through universal screening, universal asking questions of every woman who comes into prenatal care or into your hospital. This is not drug testing. This is doing a standardized intake form that asks the key questions. And then, as we're going to talk a lot today, it's about optimizing treatment of women with opioid use disorder, which involves access to MAT for pregnant and the postpartum women. As I mentioned before, postpartum is where things can often fall apart. We have a prevention angle here, which I'm very pleased to say that ACOG District 9, or California ACOG, is going to take the lead on, which is reducing the use of opioid prescriptions among delivering women, because with 500,000 births in California, that's a huge number of women potentially getting opioids that we can have direct control over as maternity providers. There's a lot of work being done on that in this state already. I was at a meeting over the weekend, and UCSF has done some very nice projects about very low rates of opioid use with still good patient satisfaction. So there's real opportunities there, and I think that's going to spread very quickly with ACOG leadership on. Okay? But I think the last one is what I think we all should think about. You know, what is at the end of the day that we want? We want the mother and baby to go home together, because the long-term goal is really to have an intact family. And what can we do to, and that's why it's sort of more holistic than treatment. It's more holistic than just treating NAS, all of which are critically important, but we really want to be able to have an intact family at the end of the day, because that's what's going to be best for the baby long term and best for the mom. You know, as Corey said, you take the baby away from the mom and there's hell to pay. In terms of spiraling into depression on the mom and anger, et cetera. Next slide. So this is the bundle implementation guide, which follows that, and we're going to go through a number of the items there. But first, you know, if you're going to do this locally, you have to do this multidisciplinary with all the different folks that we've started to talk about it even more. So you have to have a local team in your community to really address this. Because a lot of this is about communication among providers, communication between outpatient and inpatient, communications between the mother and all the providers. This is kind of an inside secret, is that, you know, women with addiction are hard, anybody with addiction is hard to reach. But pregnant women do have an incentive to make change. And that can be played upon. And so we should look at that as a real opportunity to reach in and improve the lives of, not just during pregnancy, but long term. Readiness involves a fair amount of education for our providers. That substance use disorders are chronic conditions. There's nothing you can do really quickly to change it, but you have to look at the long term. We've already talked about stigma and bias, but that's really negatively impacts all kinds of care for pregnant women with OUD. And then there's some really important trainings that I would encourage locally, including trauma-informed care, to reach these folks in a better way. So we've had a little taste of the neurobiology involved, but I think there's more to learn on that, which is part of trauma-informed care. A lot of these folks have trauma in their history, either childhood trauma, sexual trauma as young adults, et cetera. And those need to be screened for and given care for. What we have seen in a lot of places is the lack of coordination between providers for substance use disorder, the obstetric providers, and the hospitals. And that's really an important linkage to establish and maintain. Next. So, you got to have a network locally to take care of folks in this setting. And these are some of the examples that you'd want to set up by your local team. Case management, mental health, obstetric care providers, primary, the obstetrician is going to check out 6 weeks from the care of this woman. So you really need to have the primary care folks involved to carry the mantle going forward, et cetera. So it's kind of, as I work in the Bay Area, it's very hard to figure out who is going to provide substance use disorder treatment for pregnant women as a practicing obstetrician. That's not something that's quickly on my Rolodex. Okay? Or who remembers what a Rolodex is? I'm sorry. in my cell phone, shall we say? So that's a big step, is to be able to share the knowledge of who is good in your community at taking care of pregnant women with substance use disorder, and that goes along because the reasons that one of the main reasons that obstetricians or other maternity care providers don't screen everyone, they don't know what to do next step. And so you have to be able to have those steps in place for it to work. Sort of similar to the arguments back and forth that we've heard this last year about universal screening for depression. What do I do next? And the key is to be able to have those resources readily available. So this is really a key step. It's sort of interesting about how there are state laws about who you report to Child Protective Services and things like that. They are variously applied in our counties. And I think this is a real opportunity to work with your local Child Protective Services and have them be part of the team here. They have a mission, though, to protect babies. Their mission isn't so much to protect mothers. But if we can convince them that the best thing for the baby is to keep the mother-baby together, and here are the resources to support that, that's a little different viewpoint of it. But that has to happen locally. The last big bullet on the readiness is developing pain control protocols for and order sets, not only for less opioid use for non-opioid exposed women in childbirth, but what are we going to do it's a complicated story about what we're going to do for women who have opioid use disorder, are on MAT. How do you provide pain relief in labor for them? So that's a whole different set of protocols that you need to have in your birthing facility. Next slide. There's a fair amount of education for the mom here in terms of we really do want moms to be on medication-assisted therapy and behavioral therapy. That's better than, as we'll show in a moment, ACOG and others are very strongly against trying to completely withdraw women during pregnancy, which is still in some of the legal systems in parts of our country, but not in California. But this follows a very significant amount of family and peer education, because we're looking at them as support. And then there's a variety of education about what to expect during, for the baby. What is NAS and how it can be best be treated. And this is, again, why this is not only about the mother, only about the baby. You have to work the two together. And so we have a whole session on that coming up. Some MAT in data from Massachusetts has been clearly associated with reduced overdoses in pregnancy. Those are the black lines. The purple column are those with MAT received. No treatment received are much, much higher rates, particularly in the postpartum period, as you see. Again, that's where the biggest danger is for the mom. So the readiness, lastly, is, we've talked about this mostly, is really working on a safe care plan for discharge. And then that's part and parcel your step for working with Child Protective Services to ensure that everybody feels comfortable with the next steps. So when we look at recognition and prevention, this is how we screen everyone. Readiness was all the preparatory stuff that you'd like to get together with that local team I was talking about. Now this is putting it into practice. How are we going to screen everyone so we can identify women and make certain they get into treatment? And there are several different screening tools in place. And it's recommended that each prenatal care provider have a standard one that they feel comfortable using and use it on everyone, no matter what their SES is, no matter how they look, but it is something that's universal. SBIRT is one that you may be familiar with, but you also want to screen for other substances besides opioids. There are many options, as I said. There's 4P, 5PS, 5P plus, so some of those are the most common. You should be familiar with some of these, but it really, at the end of the day, it doesn't matter so much to all the experts we had in the room, as long as you have a standard one that you're using and comfortable with. But there are some nice ones that have been used nationally that we are referencing to. Next. This is the SBIRT one, and you can read through the on the slide set a little bit more detail, just showing the examples of the next. So ACOG has come out very strongly that MAT is the recommended course for pregnant women in pregnancy. They're not coming out saying that buprenorphine is better than methadone, though you might argue that, but you need to be on MAT rather than medically supervised withdrawal because of the very high relapse rates and then the potential for overdoses. And if you relapse, you're going to relapse more with street drugs and the fentanyls and very much more dangerous things that are out there. So what do we do then with folks who have opioid use disorders? This is then what we call the response part of the bundle. And this is where it's really about linkages of services, support services elsewhere, and incorporation of things like breastfeeding support or lactation counseling, as we were talking earlier, postpartum LARCs, pain management strategies, infant care. So it's not only during pregnancy, but afterwards. And there's some nice resources available now. This is, again, an example we have in the links that I'm giving you later. We'll take you to all these resources. Next slide. I mentioned earlier, and this is where we have often failed in the medical system, which is the coordination of care. And as you're starting up programs, I would really recommend this to be a key part of it. So not only the providers who are taking care of the mom, and then potentially the baby, and then afterwards, but there are also comorbid conditions that you have to be looking for here, because these folks have multidimensional issues. So the last R, and there's 4 R's of all the national bundles, is about reporting and learning from systems learning. And so we have a set of a very small, simple set of recommended measures that we are doing in all the states that are embarking on this, in all the areas. And we're going to describe a few of those. And we're in CMQCC. One of our roles is helping support data collection and allowing you to compare and contrast to others working on the same issue. And we've done this with hemorrhage, with hypertension, C-sections for all those working in hospitals. This is a pretty common deal. Some of the opioid measures are obviously statewide. We're going to be following pregnancy-associated opioid deaths and something easily calculable, both for a health plan or for a state basis, is the average length of stay for neonatal abstinence syndrome. It's not perfect. There are pros and cons, but it gives us a picture. But process-wise, we're looking at what proportion of women with opioid use disorder who receive MAT. We're really pushing that people who we recognize get into treatment during pregnancy. Okay, so that's a process measure. And the number of mothers with opioid-exposed newborns, a little different definition there, who get mother's milk. Okay? Because that's one of the key ways of creating that bonding and better for the baby. And the proportion of opioid use exposed infants that go home with their biological mother. And that's not going to happen every time, but we really want to maximize that effort. The structure measures are for a hospital, have you implemented a universal screening protocol? And we're also looking at prenatal care sites, asking them, are you universally screening for opioid use disorder? Has your hospital implemented post-delivery and discharge pain management prescribing practices? Looking at, so you're not clicking a button on your electronic health record and say, okay, she can go home with 30 pills of Vicodin. Easy to do with the standard order set. Those all have to be thrown out and redone. Okay? Has your hospital implemented specific pain management and opioid prescribing guidelines for patients with opioid use disorder? We have some standard or some example new prescribing patterns that and order sets that can be used in facilities. This is a very tricky one. So these are links to the bundles, the bundle resource list, and the implementation resources. So this is what's hot off the press, and really very good stuff on that link. So this is our national collaborative has been pulling together resources from the states who are ahead of us on this. The Ohios, the Illinois, the Massachusetts, which is part of our national quality improvement effort is to share resources across the country. So this is an opportunity for us. Next slide. And this it really gets into what do I do first when you have a long list of things. In the bundle guide, they're essentially put into order of what you would do. So look at it that way. So I'm going to turn to what we can capture locally with our data. And as you may know, in CMQCC, we've set up a data collection system that is pretty real time and low burden for every hospital in California. The Department of Public Health gives us de-identified birth certificates for every birth in California 45 days after the end of every month. Okay? We link that with hospital discharge data, which is for every mother and every baby, also 45 days old. Okay? And we link those together. So this gives us a pretty robust data set that we use, that we allow every hospital to see how they compare to other hospitals, anonymously, or in your region, or in your like size. So 500 birth delivery hospitals can be compared against 500 birth delivery hospitals, and a whole series of interactive web-based tools. Right now, you can go into any hospital, and Partnership has been a great partner for us on this. And so every hospital in your region is a member, and actually 213 out of 240 of California hospitals are in the rapid cycle approach, which is the 45-day approach. So every hospital that's represented here is a member. And so you can go into the hospital statistics page and look under baby prematurity stats. And then as one of them is newborn drug withdrawal and exposure. These are the codes that we use. And there's basically a couple of different types. One is NAS and the other is babies affected by newborns. And the codes are changing this month. At the end of this month, there's going to be a specific one for opioid. So this is what you see. This is what a hospital sees. This is over time. This is actually one of the hospitals in the partnership catchment area in Northern California. One of your hospitals that you could see, blue is NAS and green is newborns affected by drugs of addiction. And you can see over time it's trending upwards. Next slide, you can also look at, this is by region of California. And the ones that stick out are the North Coast East Bay perinatal region, which is essentially San Francisco up to Oregon along the coast. And then the second RPPC Regional Perinatal Programs of California region is Sacramento up to Oregon along the Central Valley. And those have the two highest NAS of any region in California. You know, what's fun about this is that you can click on the legend in the bottom. You know, the blue-red is, so if you click on any of those will disappear. So we clicked on those, leaving just the blue. Next slide. So now you're just seeing the blue. So it's interactive. Well, I think I'm finished.